Hello, my name is Dr. Adam Cohen from the Abramson Cancer Center at the University of Pennsylvania, and I'll be talking about our abstract exploring the use of BCMA-specific CAR-T cells in conjunction with cyclophosphamide conditioning for relapsed refractory multiple myeloma. BCMA stands for B-cell maturation antigen. This is a cell surface receptor that's expressed almost universally on both normal as well as malignant plasma cells, and also plays a role in myeloma pathogenesis, which makes it an attractive target for immunotherapy. And so several groups are now looking at the use of CAR-T cells targeting BCMA as a means to try to treat and eradicate disease in the relapsed refractory setting. The CAR construct that we're using is a fully human scFv targeting BCMA with CD3 and CD3 and 4 and BB co-stimulatory domains packaged in a lentiviral vector. And so it's an autologous T cell product. Patients have a leukapheresis to collect T cells. There's a 3 to 4 week manufacturing process, and then we reinfuse the CAR T cells into the patient. And so this is a phase 1 study, and we're exploring 3 different cohorts. The first are patients just getting the CAR T cells alone without any lymphodepleting conditioning at a dose of 10 to the 8th CAR cells. Cohort 2 is using cyclophosphamide with a 10-fold lower dose of CAR T cells, 10 to the 7th, and Cohort 3 uses cyclophosphamide conditioning with the higher dose, or 10 to the 8th CAR T cells. And so we've enrolled and treated a total of 24 patients. 9 patients were treated in the first cohort, 5 in the second, and 10 in the third. And these were heavily pretreated patients with a median of 7 prior lines of therapy. Many of whom were penta-refractory to available myeloma agents, and almost all of whom had at least one high-risk cytogenetic abnormality. In terms of safety, the primary toxicities in our trial are similar to those seen in other CAR T cell trials, namely cytokine release syndrome, which was seen in 20 out of 24 patients, including 6 or 25% who had severe grade 3 or 4 cytokine release. And fortunately, this is treatable with IL-6 directed therapies such as tocilizumab. The other primary toxicity in CAR T cell therapy is neurotoxicity, and we did see this in 6 out of 24 patients, or 25%. 3 of whom were low grade, 3 of whom, however, had grade 3 or 4 encephalopathy that was more severe. Fortunately, though, again, did recover with supportive care and in some cases steroid therapy. In terms of efficacy, in the first cohort with CAR T cells alone, we saw objective responses of PR or better in 4 out of our 9 patients, including 1 subject, actually our first one treated, who remains in astringent complete remission now 24 months or 2 years after receiving CAR T cells without any intervening therapy. In cohort 2, at Cytoxan with the lower dose of CAR T cells, there was less efficacy with only 1 partial response that lasted 2 months, as well as a minor response and stable disease lasting 4 to 5 months. And in the Cohort 3, the cyclophosphamide with the higher dose of CAR T cells, 10 to the 8th, we have 10 patients evaluable so far. 6 of those 10 have had a partial response or better, and another 2 have had minimal responses. That includes 1 patient with an ongoing complete response at 6 months, and 2 other patients with ongoing partial responses at 3 months. Follow-up, of course, is much shorter in this third cohort. So overall, we're seeing responses in 11 of 24 patients, or 47%. 10 of 19 at the higher, more effective dose. The median duration of response has been roughly 4 months. And so I think to summarize, this really confirms BCMA as an attractive target for multiple myeloma, and together with the other CAR T cell data being presented at this meeting, I think this represents a really exciting new approach to myeloma therapy. I think there's a lot we still have to learn about CAR T cells, including the optimal patient populations to try to put in, whether we need to screen for BCMA expression beforehand or not. Our study, for instance, did not have any pre-specified level of BCMA that was required to get into the trial, which differentiates from some of the other studies. And of course, the best ways to try to mitigate the toxicities, particularly cytokine release and neurotoxicity. But I think this is a promising initial effort, and certainly supports further exploration of this approach.